This is the last session of our series in chronic edema and lymphedema, and I'm pleased that you're all here rather than outside in the nice warm weather that we finally have. So I'm really honored that you did choose to come and listen to the sessions tonight. Tonight we have 4 speakers for you, and the first 2 ladies that are speaking, I'll introduce them and they'll tell you a little bit more about what they're talking about. And then after that we have Ian Souls coming again to talk a little bit to us, and Dr. Rao will be also talking to us. So Heather Watt graduated from the University of Alberta with a Bachelor of Science in Occupational Therapy in 2000. Since then, she has worked in various positions within Alberta Health Services, mainly in community rehabilitation. She has been treating lymphedema for the past 5 years, and in March 2013, she became a certified lymphedema therapist through the Norton School of Lymphatic Therapy. And joining her tonight is Darla Larson, and Darla is a graduate of MacEwan in 2002 with the diploma in physical therapy. And Darla also works with Heather, and she is also a certified lymphedema therapist. So I'll let them go ahead and start tonight. So. You can do that, or you can just click. Yeah, you can do the arrow too. We should have probably discussed this before.
Thank you very much. So thanks for having us. So we're, as Shirley said, we're from the Community Rehab Interdisciplinary Service. So we call it the CHRS Clinic, and we're going to be talking to you a little bit about what our clinic provides. And then we're going to, originally we were asked to present some case studies. So we have a few case studies that of clients that we've treated that we're going to present and hopefully find interesting. So CHRS is an ambulatory rehab service for adults with complex rehab needs. So we're an allied health program under Alberta Health Services. So we have a multidisciplinary team, occupational therapists, physical therapists, speech language pathologists. We have a recreation therapist and a social worker. So this part of our clinic, we see people with MS, Parkinson's, stroke, people with chronic progressive disease. For the last almost 5 years, we have implemented lymphedema services into our clinic. So we treat lymphedema that is not caused by cancer. People that do have cancer-related lymphedema, we're referring to the Cross Cancer Institute. And this was just felt to be a huge need in the community to specifically have that treatment for non-cancer-related lymphedema. So most of those people with non-cancer related are lower extremity edemas that we're seeing. Myself, I'm an occupational therapist, and Darla is a therapy assistant. We're both certified lymphedema therapists for about a year now, and it's just the 2 of us running this clinic, the lymphedema clinic. So we see clients that are referred by a physician. We will also accept referrals from ET nurses or nurse practitioners. Most importantly, we just want that physician or the family physician know that the client is coming to our clinic and going to be seen for assessment and treatment of lymphedema. Again, we treat non-cancer related lymphedema, and if we get those referrals, we will kind of look at their history and make sure that a referral to the Cross is appropriate. We do prefer that our clients be cognitively able to comply with treatment. It's really, really important. We teach a lot of self-management with this condition, and we need them to be cognitively intact. And we do treat people like that, but often they have a caregiver that comes with them and ensures that the treatment we're providing is safe for them. And most importantly, we need our clients to be willing to wear compression lifelong. So that's a discussion that we have right off the bat. And if they're not willing to do that right now, we kind of postpone treatment, and maybe it's not the best thing for them right now. So this is what we provide at our clinic. We are going to discuss all these points in more detail. So we do a full lower leg assessment, including the assessment of circulation. We obtain a very comprehensive medical history. This helps us to determine the course of therapy. We do treatment, active treatment to reduce lymphedema. We can provide compression garments. So we are able to recommend daytime and nighttime compression garments. And again, most importantly, we're providing a lot of education on long-term management, self-management of lymphedema. Are you having trouble hearing me? Sorry, is this the phone here? How's that? Better? Okay, sorry about that. And we are able to provide yearly follow-ups for our clients, and we implemented this so that we can ensure that our clients are maintaining the reduction that we achieved with active treatment. And again, we'll discuss that further. Okay, so active treatment, or you may have heard this as described as phase 1 lymphedema treatment. Our main treatment is compression. So we use 2 types of low stretch bandages. We have 2 options. The first is a 2-layer compression system that we can apply twice a week. We only are treating clients 2 days per week, so it does limit, that's one of the limiting factors in what type of bandage that we can apply to our clients. And we also consider a reusable compression bandage, and this is for clients that are able to bandage themselves. The clients that we see very infrequently are able to bandage themselves because they're usually quite overweight and would have extreme difficulty reaching their feet and being able to do that bandaging for themselves. So there's a lot of factors that go into why we choose either of those compression. We have to look at what this person is doing day to day. Do they need to wear shoes? Do they need to drive? Are they working? Is their work very active? So we do obtain a good history to make that decision for them and have that discussion with them on what they feel is going to be easy to do for them in their life. So every session we measure the client's leg, just circumferential measurements up the leg to monitor the reduction. We do skincare, make sure the skin is healthy. We do have access to a nurse through home care. They're conveniently located across the hall from us, so they have been more than willing to help us out because we're definitely not trained in in wound care. So and they are excellent, and they've actually allowed us to see a lot more clients than we would have been able to without them. So it's a great service for us. Again, really important, we teach a home exercise program. We even have clients check off that they're doing it regularly. We encourage walking, strengthening exercises in the legs, and deep breathing exercises. And that's, again, just to further stimulate that lymphatic system. We are trained in manual lymph drainage. It's not part of our regular treatment. We kind of use it as we feel it's necessary. So go on a case-by-case basis for that. And again, during active treatment, we're constantly talking about lymphedema management, self-management. We want our clients to be self-managers of this condition when we're done. And it's just an extremely important skill to have. So we're constantly talking about compression, that they will have to wear compression stockings, that they might have to wear a compression garment at night, that they will have to maintain good skin care, they will have to continue exercising, maintaining a healthy weight, eating a healthy diet, and possibly go for manual lymph drainage regularly. All right, I'm going to pass it on to Darla.
So the second phase of lymphedema treatment is what we call the maintenance phase, and we start thinking about the maintenance phase as soon as we meet that client, because we need to make sure that they understand that once we're finished treating them, that there's this whole other side to things that they have to kind of agree to or be willing to adhere to. So once their edema reduction plateaus, we have them measured for the appropriate compression garment. In our clinic, we bring those vendors to us to do those measurements, and we do that because we like to get measurements the same day that they go in their garments. That's when we feel we've got their leg down the most. We work a lot with the vendors to kind of determine what garment's going to work best for that client. There's lots of different options out there. They know about the garments and how to measure, but we know the person's limb and how they've responded to treatment. And those garments take 3 weeks to get in. They're made in Germany usually. And so the clients have to be bandaged until the garments come in. Heather is actually able to authorize through Alberta Aids to Daily Living if the client doesn't have funding or benefits to cover those. So it's easy for us to kind of get that going and get those garments on the way. We are thinking about nighttime throughout treatment as well, because we're much better now at kind of determining if we feel the client's going to need nighttime compression. Many people that we see aren't going to be maintained in just their daytime stocking. They get refill in those stockings, and without a nighttime compression, they often end up failing those stockings after about a month. So if we, most of our clients, our larger clients, most of them have had long-standing lymphedema, and so we know that nighttime compression is necessary, and so we need to start thinking about it before the stockings arrive, because we can't send them home in their stockings without that second added piece. That's what's going to really help them be successful. So once our stockings come in and we're happy with the fit, we make sure that they know how to get them on, they can get them off, or they have support to do that, because that's kind of crucial as well. If they can't get them on correctly, they're not going to work very well. And if everything's going good, we'll leave them for a week and then monitor them to see if those garments are working. Once we're satisfied they are, then we can kind of leave them for about 6 weeks. If they're not working well, then we have more problems to solve, because we need to make sure that everything is going well before we stop seeing that client. So at the 6-week visit, we'll make sure that they're happy with their garment, they're getting them on and off properly. They leave that day with a piece of paper that actually outlines exactly what we're expecting from them, what we think they're going to be wearing at daytime and nighttime. We review again, you still need to exercise. It's not okay now to stop just because you're in your garments. There's lots of those pieces. Weight management, we always go over that from the beginning. And we recommend in that sheet that if it's possible for them to go for maintenance massage from somebody who's certified in lymphatic drainage, it would be really helpful in just increasing their being successful. And then if everything's going great, we'll follow up with them yearly. Our super complex clients maybe a little bit more often than that, but for the most part, now that we've kind of gotten them all those pieces of paper and they can go home with it, we're able to follow most of them once a year. So the next topic for us to bring up is obesity management. It's something we figured out very early was going to be a huge component for our clinic. We see a lot of clients coming through our door that have swelling that we believe is secondary to their weight. It's not every client for sure, but we kind of have to tease that out a bit, because in our experience, we've struggled a little bit with this client and actually being able to treat them and maintain them. We can't say exactly why that these clients have the lymphedema, but we can surmise that they have a lot of extra tissue, their venous systems don't work as well, then in turn their lymphatic system is compromised. So they're often a combination of edemas. We can surmise that they have a lot of weight around their midsection, maybe a lot of pressure on those nodes, and it's difficult for fluids to exit their system. They're often not very physically active either. So there's a lot of factors that kind of contribute to it. And in our experience, we found that the management of their lymphedema is extremely difficult. We can wrap these clients, but often we're just moving the problem around because, again, we're struggling to get it to actually leave their system. There's a lot of risk to wrapping them when they're heavier. They're at increased risk for cardiac concerns, but they're also more prone to having that fluid pool in places that we can't then treat it very well. So we wrap their lower leg, it pools in their thigh. You wrap the thigh, it pools in their abdomen. So every person that comes in is going to get that assessment, and our job is to kind of sit down and tease out with the medical history, looking at their legs. We look at risk factors. Do they have wounds? Have they had wounds? Do they have a history of cellulitis? If they're really low risk and they look pretty healthy, we've added a component of weight loss to our lymphedema clinic, just because of the number of these patients that we're seeing. So Heather and I both recently went and had some additional training in supporting people with weight loss, because we know from the people that we've tried to treat that we're failing these people in treatment. We can get that fluid out sometimes. Maybe we might even be lucky enough that it doesn't sit somewhere we don't want it, but then we can't keep it out, right? We've got them in stockings, it's not holding them. Many of them can't afford to buy those garments that are needed for nighttime control. And so they go through all of this wrapping and then they're failing in that maintenance phase very quickly. So if they're low risk, we definitely want to keep seeing them. We both wanted to get a lot better at knowing what's out there for resources and how do we help them, how do we talk with them, how do we support them. We've had every single client agree to being referred to a weight loss program, but there's waits for that as well. And so, we want to make sure that we're not sending them out that door. So they come back in for regular visits, we monitor their skin, we monitor their swelling, we set weight loss goals, and so far it's been really successful. And we've had a really good response in building a relationship with these clients. So hopefully, as we're following them and they get referred to a program and they start down that road, we can start treating them. That's really what we want to do. And it's made us a lot more aware of what's out there for these clients as far as support and whatnot. So that's just a new thing that we've added in the last few months, and hopefully it's going to grow a little bit in our clinic, because I think there is a real big need to address that problem, and especially in relation to lymphedema.
All right, so as I mentioned before, we're going to present 3 case studies of clients that we have treated at our clinic. And we do have pictures. Here's one. So this is Diane. Hopefully I don't call her by her real name. So this is how she came to us. This is a picture of her from behind. So she's a 66-year-old female. She reported about an 18-year history of swelling in her legs with recurring wounds. She thought that the edema started about 18 years ago after an infection. And that's something that we often hear, because a cellulitis or an infection in the skin will damage the lymphatic system more, and that just makes the condition worse. And that's why skincare is so important in managing lymphedema. So her skin was very poor. The picture before, she had a lot of blistering or like skin projections, and some of them filled with fluid. Again, they would burst and she'd have wounds, and then home care would be in trying to help with that. She had numerous attempts at compression wrapping. She was only ever wrapped to the knee. They tried all sorts of things, and it was scary actually what she came in. She came in wrapped in fleece, pieces of fleece.
With duct tape.
And it was just because she was so frustrated that this is what worked for her, this is what was comfortable with her. But yeah, it was a little bit scary. But it really was. She was from out of town, like about 5 hours out of Edmonton, so she did have to relocate to Edmonton to get this treatment. But they just didn't know how to treat this condition. Her mobility was severely impaired. She had to use a scooter. For long distances, she was able to ambulate or walk within her home, but very short distances. Her weight was about 319 pounds and she was about 5'2". So I haven't calculated that BMI, but it's probably a little bit high. So we can suspect that this is probably a lymphedema secondary to her weight and these cellulitises and infections. So this is her after treatment. So we just have a few stats here. We used the 2-layer compression system and wrapped her twice a week to the thigh. So, and by thigh I mean groin. So we get right up there, and if we don't, then the swelling just kind of goes right over the top of the wrap. So we did 12 wraps, which is 6 weeks basically, on her right leg and 9 on her left leg. We removed 9.6 liters of fluid, so it's almost 5 2-liter milk jugs, and 7 liters from her left leg. Her weight reduced to 308 pounds post-treatment. So a lot of that was fluid, And regardless of that, this lady really, really has to work on her weight management. She is someone that we could not wait to lose weight because of her skin condition. It was just too risky. So we really felt like she needed this treatment. So to maintain this reduction, she's gonna have to do all the work now. So she needs to wear custom thigh-high stockings during the day. And for her, we had a chap style, so they actually come up to the thigh and then have a hip portion and actually attach. So we've just found that that helps with the stockings to stay up a little bit better. Absolutely, she has to wear a compression garment at night. This was a very expensive garment for her for both legs. I think it was about $1,000. And that's actually inexpensive for nighttime compression. She will absolutely have to continue to lose weight or at least maintain her weight. She has to stay active. She has to maintain her skin health. We reduce the edema and cause more skin creases and more areas for things to grow. So we really do a lot of training and make sure that clients can wash and dry in their skin creases and make sure those stay healthy. She also, all those blisters and skin projections that she had, some of them actually went away, but some of them ended up as skin tags. And so those again are going to be a source of infection, a source of problems for her with the shearing forces of putting stockings on and stuff. So unfortunately, we haven't been able to follow up with this lady yet. We're going to see her in June, so I'm really excited to see how well she's doing. And again, she does know someone from her hometown who is certified in manual lymph drainage, so she is going to try and do that regularly, so that's really great. All right, so this is just a before and after picture of her. We're pretty proud of this one. We're actually proud of all of ours. And Darla's going to do this one.
So this is Paula. We tried to pick a few different ones from what we see. I mean, like I said in the earlier talk, we do see a lot of clients that have swelling that is most likely secondary to their weight. But because we're treating non-cancer related lymphedema, we see pretty much anybody else that gets swelling out there that isn't able to be seen for that. She's a 58-year-old female with a 4-year history of swelling in her left leg only. She did have a wound in her left leg and had actually been treated with compression for her swelling and the wound, and it healed the wound. They put her in stockings, things were going well, but she wasn't maintained. And again, she was in a below knee stocking, probably needed a thigh high. She didn't have nighttime compression. So there was probably a couple of reasons why those stockings failed. But they healed her wound and it was a start. So when she came to us, she actually wasn't wearing anything on that left leg. Was an interesting one for us because previous doctors on the referral had actually thought that perhaps they queried filariasis, which is not something we would expect to see. It's the leading cause of lymphedema in the world, but it's mostly seen in third world countries. It's a parasite that's carried by a mosquito, and if a person's infected, it actually damages the lymphatic system. The larvae that are in there actually damaging the system. I think they queried it with her just because she actually had been in some countries where that was a possibility, and there really isn't medically any kind of an event that would have triggered this, so it was just interesting to us. It doesn't change the treatment, but you read about these things when you go through training, so it's just kind of interesting to see somebody that they actually think that could happen. It didn't help her get any tests for lymphedema. They typically don't do a lot of that here, which we would love to see changed actually. So we wrapped her 9 times and we removed 4 liters of fluid, which is a little bit more dramatic if you could see her because she's not 5 feet tall. She's a little tiny lady, and so there was a lot of fluid in that leg that she was packing around and working all of her jobs, and it didn't slow her down, but it was definitely a big hindrance to her. And she just, even with still being in bandages because her garments haven't arrived, she says she notices quite a difference to just walking with that leg. So to maintain this reduction, she's going to wear a custom-made thigh-high stocking during the day. We absolutely knew that she was going to need nighttime compression. Previous compression had failed. It was a fairly significant lymphedema. Her foot is very involved, and we find that those people generally have a lot of trouble maintaining. So she's actually gone ahead and gotten and purchased a nighttime garment, so when her stockings come in, she'll be able to wear them home and use that bandaging alternative at night. She needs to maintain a healthy weight. She's a very slight lady, but again, she's 58 years old, so just knowing that if she gained weight, it might make it more difficult to maintain the reduction of her edema. Activity, again, she's working lots, but just those specific exercises we teach that are really designed to take advantage of the muscle pump and make sure that the circulatory system's getting all the help it can get. She has a lot of deep crevices in her foot. I think like they're almost an inch deep. And so she has to really take care of that to prevent any kind of risk of infection. We will definitely recommend to her, if she can, to go and have some massage on a regular basis. Again, she has a lot of fibrotic tissue in her foot, and it would just be helpful for her, I think, if she could go somewhere regularly and just kind of have that done. It's probably going to help her maintain quite a bit. So there's just a difference, you can just see the difference in her left leg. Oh, sorry.
That's okay.
I'm done.
So this is Jane. This was a really exciting case that we treated. So these are her front and back pictures. She actually came, she's only 25 years old. She again was from out of town, kind of a smaller town, a little bit isolated. So she reported swelling for about 5 years, might be a little bit longer than that, but she believes it started after an ankle sprain. So again, we try and get all the history that we can, and we kind of make our guesses as to why this is happening, but we do kind of think with Jane that it probably was a congenital lymphedema. So for her, she wasn't born with it. There's two types. One is shown up at birth, and the other can show up anywhere from 12 years old to 40 years old, 50 years old. And we hear this a lot. My edema started after I had an ankle sprain or a fracture or a surgery, and then it just didn't go away. It didn't go away, and then it just slowly got worse. And so we kind of think that maybe that person was actually born with less lymphatic vessels or less nodes, and their system was compromised to begin with, and then with this fracture or this injury caused that system to kind of overload and then not function as well anymore. So just doesn't take up that fluid anymore. So again, we just guess. We don't know for sure, but it doesn't matter. Again, it doesn't really affect how we treat this person. So her mobility was limited. She was able to walk. She walked into our clinic with a cane. Again, she's 25 years old, so it was a bit of a struggle for her. She never had any treatment for this. So anybody from where she was from were too scared to even touch her. So thank goodness she found us. And she never, luckily, had any history of wounds or a cellulitis. So her skin was actually fairly healthy compared to others that we see. So this is her post pictures. We actually only treated her left leg. So somebody else treated her right leg. So we treated her left leg at the clinic. We did 10 wraps. So again, we used the 2-layer compression system twice a week. She had to find a ride to get into the city. So, and they just couldn't afford it. They couldn't manage anymore. So we reduced her left leg, which was her worst leg, and we had an OT and a nurse come from the town that she lived in, and we taught them how to wrap. So they maintained her left leg while her stocking came in, and then they decided that, yeah, we could probably handle this. So they treated the right leg, and it got like that. So we don't have pre and post treatment numbers for the right leg, but the pictures show it all, right? So, and again, we moved 8.6 liters of fluid just from that left lower leg. So she was fortunate enough that we were just able to compress her to the knee, and we always measure above where we're compressing, because we do not want that fluid going into the thigh and sitting in the thigh. Her thigh was very well maintained. Could be because she went from 307 pounds to 248 pounds. So again, she just became a lot more active. She was eating healthier. She was feeling a lot better about herself. She came in to our clinic looking very depressed and sad and just, you know, not healthy 25-year-old woman. And, you know, she came for her follow-up with makeup on and nice clothes and just feeling amazing. It was amazing to see the difference in her. So these are some outcome measures that we do. So we do a tug, it's a timed up and go, it's a mobility assessment. And it reduced from 17 seconds to 8 seconds. Her weight, again, reduced significantly. And her quality of life, where 1 is a low quality of life, 10 is a high quality of life, increased significantly also. So we made some pretty amazing gains with Jane. We're pretty proud of that one too. And that is it. Oh, right. So again, this is Jane in her custom knee-high stockings. Most of our people do go into a custom stocking. It's a flat knit stocking, very, very thick. People usually look at it and get really scared, but it definitely is the most comfortable stocking for them to wear, and it's really the only thing that will maintain their edema. So we taught her how to bandage her legs at nighttime, so she's able to do that on her own, and she can get her stockings on and off on her own. It's a real struggle at first, but she was able to get it done, so we're really happy with that. She, again, has to maintain her weight. She has to stay active, has to watch her skin, and if possible, I don't think it will ever be possible for her because of her income, but if she can get that manual lymph drainage done regularly, it would benefit her for sure. This is the part that's probably the most difficult part of this treatment. When we first started this clinic, we thought reduction would be the tough part, but it's not. It's maintaining them and teaching the clients how to maintain. It's finding the right stockings and the right garments. It is a very difficult thing to do. So, and these are her pre and post pictures. So that's it. These are our some information. For us, we do again with Alberta Health Services. It's our email address. This is our clinic number. We don't actually man this phone. You leave a message and we'll get back to you as soon as we can. And then our fax number. We are on the Alberta Health Services website finally. So you can also find information about the clinic on the website. Does anybody have any questions? Oh my goodness.
For assessment right now, they're looking at 8 to 10 weeks.
About 8 to 10 weeks for assessment. So we try to get our assessments done as the clients come in. It's really hard to say for treatment because we don't know what the clients are looking like, right? We just get them on a piece of paper. We don't often have a lot of information to determine how the treatment's going to look for them. So we actually run a wait list for our assessments, and we run a wait list for treatment. And often, we can't even treat the clients because they're from out of town. So then we have to do some wayfinding for them. So this is why we like to get those assessments in. We try to do them regularly to weed those guys out and get in.
Referral from another hospital, would it be quicker to get them in?
The only way we would consider that is by risk. And if the client is being actively treated with compression as an inpatient, we would probably take them.
Or as an outpatient in the clinic?
If they're already being treated, just to not waste that time that somebody's already put in, we would consider it. We'd have to know the details and things like that, but yeah. Yeah.
For your last case, Jane, how often would you recommend manual lymph drainage?
Well, once a week, once every 2 weeks. It would depend. It's really hard for us to say because I don't know of a lot of research that's done on MLD for this population and how successful it is. But I mean, it makes sense that it would be a good thing for her to do, right? To keep that lymphatic system stimulated and active.
But she can't afford it.
And again, it's where she lives. It's definitely not accessible for her, unfortunately.
Will you take referrals from other healthcare professionals, or does it have to be from a physician?
I think I would, as long as the physician is aware of the referral. Mm-hmm.
We have to have a doctor's
We have to have a doctor's prescription when we get the stockings, so we need that relationship with the doctor. So we get lots of calls from healthcare professionals, and I suspect they often give the referral to the doctor with all the information on it. Which is fine, right? We don't mind that. It's just without that relationship, many of our clients need clearance for this treatment because of the risks. And then we have to have a prescription from them in order to put the stockings through AADL.
Do you teach self-massage to some of your clients, or is that part of the repertoire and self-management at all?
We haven't done a lot of that, no. Maybe we have a little bit kind of to stimulate the nodes in the groin.
Sorry to interrupt. We have found that it's very difficult to teach them how to do self-massage effectively. We did put together and have just kind of been playing around a little bit with, we always teach them the deep breathing to try and stimulate. We teach them the lower extremity exercises, and we have taught a couple of our people some, just some things they can do to maybe stimulate upper body prior to us doing the compression. But from what we've learned, self-massage it's very difficult for people to do it effectively. People over here waving.
I know, I was trying to get these guys done.
She's waving a lot.
Okay, go ahead.
Hey, Darla.
Hi. That's why she's waving.
Oh.
So, what are the nighttime garments like? Same as are they the flat knit, or are they different? What are the nighttime garments?
We've been, I'm not supposed to use brand names. Whatever. So we use Juxtafit by Circade a lot of. We find that it's very easy to don, and they have recently come out with ready-made sizing that actually fits. Like Jane would fit into something off the shelf, which brings down the price significantly, and it's a really great garment. So that's kind of one that we're tending to use, and I would love to experiment with other ones, but unfortunately our clients have to buy it. There's no funding. I'm working on finding some time to write a letter to ADL to try and get funding, because I do see a lot of other need besides lymphedema to use these bandaging alternatives for sure. Even in wound care, I think it would be an amazing choice.
And many people bandage themselves if they're able to. That's probably our most cost-effective way. It's just a lot of our clients aren't physically able to do that. But if they can, it's something they can do for nighttime control.
Is there a difference in the level of compression between nighttime and daytime?
Well, usually we do recommend a little bit of a lower compression. So like the Juxtafit probably does give a 30 to 40 millimeter mercury compression. The difference in the compression though is that it's not elastic. It's not something that squeezes. The Juxtafit is a very low stretch neoprene garment, so it barely stretches. So when you put it on, there's 2 lines on the strap that tells you, kind of gauges that compression. But really you're just supposed to put it on so that it's firm and comfortable and that they can tolerate it at night. So we don't really look at the numbers as much because it is a non-elastic type of compression. Mm-hmm. Yeah.
Yeah, I was just wondering, how does deep breathing work with lymphedema?
Deep breathing stimulates the large lymphatic duct in the torso. So with the diaphragm kind of moving up and down, it kind of massages the lymphatic duct, and that's the largest duct in the body. That's kind of where the legs drain to. So something that's very easy to do, people know how to do it, and it's definitely worth adding that into the treatment.
Thank you.
Mm-hmm. Yeah.
So how come you guys don't also treat the lymphedema for cancer? Because it's just cancer.
Mm-hmm.
Lymphedema is usually caused by damage.
Yeah. So the need in the community was, because cancer-related lymphedema is treated at the Cross Cancer, and up until, well, they would take referrals for non-cancer related, but it was just getting too much for them. So there was a huge need for treatment for non-cancer related lymphedema. So there is a service for cancer related. There was not a service for non-cancer related that was funded by Alberta Health Services. Sorry.
We'll move on. Okay. Thank you, Darla and Heather, very much for the presentation. So thank you very much.
Alrighty. I'm just going to be talking about some things that in some respects, Heather's covered already. But we take a bit of a different approach because we don't have the same kind of constraints with respect to tight protocols and restrictions, and basically the amount of care you can get depends on your resources and not the public sector's. So I'm going to walk through some things that are similar to what you've heard, but maybe have a little bit of a different twist. Basically, a management plan for lymphedema depends on the site of the lymphedema, the stage of it, the complexity, how severe it is, those kinds of things. And the presence and nature of comorbidities. You know, Heather and her group see a lot more comorbidities than we often do because we tend to have lymphedemas that present at a much earlier stage. As well, our management plans depend on whether or not people have previously had treatments and what their effects were, and what their physical and psychological tolerances of treatment are. One of the things that we haven't talked much about in this series is going through combined decongestive therapy, whether it's manual lymph drainage in conjunction with compression therapy and exercise, or whether it's compression therapy alone, is not an easy process. It's a process that we see a number of clients struggle with because you are in this compression, and it does affect your life during that process. And it's not, I don't know how many people have actually been in compression, but it's for any extended period of time, it's not something that is really that enjoyable. And as well, your social situation will depend upon your tolerance of it and also what the goals of treatment are. The severity of the lymphedema and the underlying condition and people's circumstances have a lot to do with the treatment approach that we take and the length of the session, the number of treatments required. So all of those things are factored into how to go about it. Treatment with respect to lymphedema can range anywhere from MLD sessions without compression for really mild edemas to intensive therapy protocols where we do daily appointments from 75 to 90 minutes for a period of 10 to 14 days. So people are coming in every day, getting manual lymph drainage, being wrapped, getting exercises, coming back again wrapped, or maybe they've been out of their wrap for an hour and they're going to go through another series of MLD and then compression. 3 phases of treatment. There's an intensive phase, which is a reductive phase. There's a transition phase where you're moving into being in full-time compression garments, and then there's a maintenance phase after that. 4 pillars of treatment that you're probably getting some good sense of: manual lymphatic drainage, compression, exercise, skin care. Those are really the 4 pillars of combined decongestive therapy. And all 4 of those are really important, as you can tell from Dr. Rao's presentation, the importance of skin care. We talked last week in depth about exercise and the value there, and you've heard a lot about compression. There are contraindications of conditions with respect to manual lymphatic drainage and combined decongestive therapy, and there's reasons to withhold it in certain situations. Manual lymph drainage accelerates lymphatic flow, and as a result, there are a number of health concerns that if you're experiencing the following situations, you need to discuss or not receive treatment. If you have untreated malignant diseases, if you have acute inflammations, recent thrombosis, like deep vein thrombosis, cardiac insufficiency, renal failure. Those are contraindications where if you increase the amount of lymphatic flow, in the case of untreated malignant diseases, there's concern that you can actually move cancer cells. With respect to acute inflammations, cellulitis is a prime example that Dr. Rao just talked about. You don't want to do manual lymph drainage in the case of an acute inflammation or acute infection like cellulitis, because you can in fact move that and move it very rapidly. Recent thrombosis, you can in fact, and the risk occurs with a deep vein thrombosis that you can in fact dislodge something, and somebody can end up with a very serious situation. Cardiac insufficiency, cardiac heart problems, where, especially in the case of congestive heart failure, where you can overload the fluid load on the heart and put someone in a very difficult cardiac situation. Or if you have a renal dysfunction and renal failure, where you're pushing a lot of fluid then through the kidneys, it's another contraindication that you don't want to go there. The intensive phase begins with determining volume of the limb, and we tend to take volume measurements. If you notice here, every 4 centimeters, 0 is taken at the medial malleolus, and then we take measurements on if this happens to be a leg, the foot, and then every 4 centimeters up the limb to the top of the limb. And then those are calculated, squared, divided by pi, and you can actually get the volume of the limb. And we, in fact, measure the affected and unaffected side if it's a unilateral lymphedema, so that we can, in fact, know what kind of volume reductions we're getting. With the intensive phase, in our case, manual lymphatic drainage is the primary difference between combined decongestive therapy and compression therapy. And we are, in fact, strong advocates of combined decongestive therapy. Manual lymphatic drainage is the real primary underpinning of that. And when we have somebody go through an intensive reductive phase with combined decongestive therapy, we're doing manual lymphatic drainage every day. It's a gentle, rhythmical massage technique, and it's very, very gentle. The weight of a nickel on your skin. It's rhythmical, and it's focused on stimulating lymph flow and moving proteins and fluid into alternate watersheds. And we talked earlier about those different watersheds in the body and how you can actually move fluid between those different watersheds and proteins as well. That's, I guess, in our view, the important thing, because you need to change the physiology of the tissue in order to actually affect a long-term change in terms of lymphedema. If all you're doing is reducing the volume of a limb, but the protein levels are still there and continue to grow, then the osmotic pressure differential will continue to increase, and the person will continue to struggle with maintaining the lymphedema. And I really agree with Heather in terms of getting people into regular manual lymph drainage sessions when you can, for the purposes of reducing that protein load. A study was done in Salzburg. They looked at compression therapy, and they reduced the limb by 33% in terms of the fluid volume, but the effect on the protein volume in that limb was only 3.6% reduction. So the actual physiology of the tissue wasn't changing considerably in the case of compression therapy alone. That's the rate of increases of pulsations that you can get with manual lymph drainage. There's a variety of studies on the effectiveness of combined decongestive therapy that are out there that compare combined decongestive therapy being manual lymph drainage and compression with compression therapy alone. The problem is with most of those is that they don't control the methodology of the manual lymph drainage, and you can't be really certain what they're calling manual lymph drainage, whether it's just stroking of the skin or is it some particular methodology or technique. And also the patient populations aren't always comparable. So in my view, there is not a solid randomized control study without problems that is yet to be done. I think that any studies that we've seen, and even there's been some big ones recently presented in some cancer journals, And there's numerous problems with those.
Can you reduce the protein by diet or no?
No.
No?
Manual lymph drainage is also the only therapeutic approach that addresses midline edemas. Now, we talked a little bit about lymph taping, which is a really good self-management technique with respect to that and can be coupled with it. But when you get into midline edemas like breast edemas, congenital edemas, head and neck edemas, chest wall edemas, how do you put compression on it? You still got to breathe. A couple of photos of some manual lymph drainage on a leg and on an arm. Compression is important during the reductive phase, and in our case, there's a number of bandaging techniques that we use. In three, in fact. We use short stretch bandages, which are an elastic bandage with a high working pressure. So when you're wearing them and you start walking around in them, you're getting a lot more pressure. We'll use long stretch bandages, which are elastic, which have a high resting pressure and a lower working pressure. And we'll also use Coban 2 bandages, which are an inelastic 2-layer bandage system. The 4-layer bandage system is the most commonly used with combined decongestive therapy. And the reason for that is you can adjust the amount of pressure that you're giving based on the number of layers that you add of the short stretch, and also the amount of stretch during the application. So where you've got an inelastic bandage system, the compression is actually controlled by the nature of the material you're working with. With a short stretch bandage, we can start with a lower compression for people that are more intolerant of compression and work to higher ones. Also, short stretch bandages are reusable, and therefore they're suited to daily combined decongestive therapy because you can wash them and put them on again. Foam padding is initially wrapped over a cotton stocking before the stretch bandages are applied. And the toes and fingers are also wrapped with a molas gauze bandage, so you're not getting swelling of the toes and fingers. Here's an actual photo of somebody with a short stretch bandage on. You can see here the foam and the cotton on the top, and then this is the bandage system that you see. I'm actually taking it off at this point. With a long stretch bandage, it's applied directly over the cotton sleeve without any foam padding. It's more commonly used on arms than legs, and we'll use it sometimes because it'll allow people to wear regular footwear instead of a short stretch with the thick, heavy foam padding. And it's often chosen as well for patients who have difficulty tolerating compression. So we'll use it with oftentimes chronic venous insufficiencies or lymphedemas a little more. Coban 2 is an inelastic bandage system that we use. It's a 2-layer rather than a 4-layer system. It's an alternative to shorter long stretch when clients can't attend daily sessions, or when they have limited financial constraints, or when they have an unusually large or irregular edema. It tends to stay up better in my view, although many people argue that point with me, but I think it does. Although the bandages are more expensive and not reusable, the way in which we take the approach when we're using Coban is we only do 6 sessions over a 2-week period rather than 12, so we can actually reduce the cost of it by using this, although we can't use the bandages. But that cost is saved because you don't see the therapist as much. It's also not useful, we've found, when we're achieving significant reductions in combination with manual lymph drainage. We dealt with a client one time who had a very large leg edema. We did a manual lymph drainage session. We wrapped them with Coban 2, and 3 hours later, we were able to take off the entire bandage system like a cast. She had reduced that much. So it didn't last at all. In fact, Jessica with 3M was there for that demonstration, and they had never seen it before. One of the problems we've run into when we don't use Coban so early in treatment sometimes is because we get really big volume reductions on the front end, and the Coban doesn't last even a day before we lose our compression. And also, we also use it following the intensive phase sometimes if we use it waiting for a custom garment. In the transition phase, it's sort of the time between we've gone through and intensively reduced somebody and they're not yet in a compression garment. We have people come in on a weekly or bi-weekly basis, and we want to continue to stimulate the lymphatic drainage. We want to check that their garment's fitting properly if they've got them in an off-the-shelf one, for instance, while we're waiting for a custom one. And we want to measure their lem volumes and review their exercises, self-management techniques. And at this point, this is when we often do the lymph taping and teach people how to apply it. We then get into a maintenance phase that we have the advantage of offering because it's a private service. 20 years of our experience has shown us that clients who receive regular manual lymph drainage have less problems managing their lymphedema. They just do. They don't, in fact, we've got a number of clients that have gone back after a number of years of getting regular manual lymph drainage and have been reassessed at the cross, for instance, and they say, if we assessed you today, we'd say you didn't have lymphedema. They have less problems with their garments. Oftentimes they don't wear them full-time any longer. And it just seems to be a much better situation. And also clients that have a more difficult time maintaining their gains that they got during the reductive phase also benefit a lot from getting regular manual lymph drainage, because it seems to be a bit of a struggle sometimes with some edemas to keep them at bay. Generally, clients receive either biweekly or monthly MLD sessions in the maintenance phase. We encourage them to wear compression on a daily basis. And we get into providing exercises that are gentle, rhythmical, specific to their condition. And I'm going to sort of skip through this because it's pretty straightforward, the kinds of things that we do with them. Simple, rhythmical, gentle exercises, whether it's an arm thing or even, you know, if you're with a leg edema, you're standing and rocking on the soles of your balls of your feet. All you're looking at doing is creating a gentle, rhythmical pulsation of the muscles to move that. CDT results vary based on individual's physiological condition, the extent of lymphatic damage, and the individual's compliance with the protocols. As a result of that, we're always reluctant to provide an estimate of the success of any particular individual can expect. People ask all the time, you know, how much is my edema going to go down? And I can't really answer that on an individual by individual basis because it depends on how damaged the system was, how repeatedly damaged it's been from reoccurrences, whether or not your alternate pathways are open more readily than others. We've even got physiological or anatomical differences in terms of us. There's a radial pathway that goes up over the shoulder in about 60% of the population. If you're one of those 60% that have that, you're going to have less of a difficult time maintaining your lymphedema than if you're in the 40% that doesn't have it. With 20 years of experiences, we've seen many successes in reducing both the volume of lymphedema and reducing tissue fibrosis. And while some clients have experienced a complete reduction in their lymphedema, that is not the norm. Our clinical statistics after a single series, which is 12 to 14 sessions, range from an 8.5% reduction to 100% reduction, with the average reductions that we're experiencing being 63%. And those are really very good numbers. What's an investment in CDT costs? This is a private service. A typical 12-session series with short stretch bandaging costs about $1,500. A CDT series using Coban costs approximately $900 because it requires half the MLD sessions. And we're currently in the process of determining whether or not those different approaches provide similar results, because I'm not sure if they do or not yet. While we recognize that cost may be a barrier, these are the two reasons we really opened a private clinic in Edmonton in 2011. Because at the time we wanted to provide best practices lymphedema therapy, and because we wanted to allow patients an option to longer wait lists and strict therapeutic protocols. We're not restricted by those because of the private nature of this service. I just want to show you a couple of before and afters, and we'll wrap this thing up. This was a post-accident crush injury. Somebody was run over by a car. And this is a before and after of a 12-day series of manual lymph drainage and combined decongestive therapy. This is a primary lymphedema that actually this photo was taken after we'd gotten through the reductive phase, and it had reduced about 50% at this point from what she started with. And this is following the CDT. The amazing part of this, and I'm just going to show you this next slide because I want to show you a peek at the future. This is what she looks like now after going through lymph vessel transplant and debulking following the CDT. We reduced her in Edmonton as far as we could. We then arranged for her to go to Munich, Germany. She went to the Whitlinger Clinic first and then saw Dr. Bullmeister in Germany. He transplanted 2 lymphatic vessels from her right leg to her left leg, each the size of a human hair. She then came back. We measured her for 14 months, during which time she reduced another 2 liters as the new lymph vessels were working. She then went back and they debulked her lower leg because she'd had a lot of fat laid down in this area after that. And she now, although she has to be in compression during the day, both of her legs are within 200 milliliters of each other. That's all I got to show you. Any quick questions? I know we're running over here.
The effects of ice and
we discourage people to be in a lot of heat, like in hot tubs, in saunas, in those kinds of things, because it increases the amount of inflammation, it increases the amount of fluid into the tissue. So you've already got an overloaded system. In terms of ice, I guess it depends on how localized, if you're talking about just icing an area or whether you're talking generally being in an icy environment. Anything that causes an increase in blood flow into that area is probably going to be stressing the lymphatic system. So, all right.
Do you teach active therapy?
I really promote it. I think that, and I covered it last week when we were talking about it, if you can get in the water, every centimeter below the surface of the water, the pressure increases 0.069 millimeters of mercury. So the amount of compression you've got on your lower legs and feet is higher than a compression garment we could put you in. So I'm a big advocate of getting in the water. Alrighty, I think it's a wrap.
Can I just ask one more question?
Sure.
Is there ever a point of, or if there isn't, is there ever a point of no return where it's gotten so bad that you can't reverse it?
You know what? I don't think so. I think that you can get gains. How much gains you can get, I'm not sure. I worked on a woman one time. She was 30 years with an arm edema after breast cancer. Her arm was huge. She had never had any compression on it. She'd never had any treatment of it. It was hard. Within 14 days of combined decongestive therapy, her arm volume had reduced 50% and her skin had softened. So, you know what? I have a lot of hope in the human body.